Hi, my name is Max Cairns, and here I'm going to give a presentation about pacemakers, implantable cardioverter defibrillators, and a case study. So in this presentation, we're going to discuss normal sinus rhythm, what defines it, um, arrhythmias, what is an arrhythmia, and what are the risk factors for these arrhythmias. Then we'll discuss what is a pacemaker, what is an ICD, and how do they fix these arrhythmias. Then we'll talk about the scope of this solution and the case study, in which we will talk about the diagnosis, the epidemiology, the pathophysiology, the treatment, and the exercise prescription. So first, before we define what's abnormal, we need to define what is normal. So this is normal sinus rhythm. It's defined by having a heart rate of 60 beats per minute to 100 beats per minute. The atria and the ventricles are contracting optimally, and they're contracting in rhythm. And the nervous stimulation for this rhythm originates in the sinoatrial node and travels through the rest of the conduction pathway without any interference or blockages. So these are the arrhythmias. These are just some, there's many more. In this one, we will go over sinus arrhythmia, tachycardia, bradycardia, sinus block and rest, PVT, atrial flutter, AFib, and VFib. So sinus arrhythmia is basically just an irregular heartbeat. It does not come around rhythmically. Tachycardia is a heart rate of above 100 beats per minute. Bradycardia is a heart rate of below 60 beats per minute. Sinus block, sinus arrest are both blockages in the conduction system that could slow the rate of the heart. Then there's paroxysmal ventricle tachycardia, which I'll call PVT, and that's when you experience a bout of very high heart rate with the nervous stimulation originating from the ventricles. Then we have atrial flutter, in which the atria contract multiple times for each ventricular contraction. Then we have atrial fibrillation, in which the atria don't contract meaningfully, and they don't effectively send blood to the ventricles. Then we have ventricular fibrillation, which is the most deadly of these arrhythmias, in which the ventricles don't contract wholly. In fact, they sort of quiver, and they don't effectively send blood to the rest of the cardiovascular system. So what are the risk factors for these arrhythmias? So in black, I've put the risk factors that we cannot affect. And in red, I've put the risk factors that are from lifestyle choices. So in black, we see family history and we see aging. Aging is one of the most important ones because as you age, you lose many of the cells in your sinoatrial node, and that can cause arrhythmias. So as people get older, they tend to see more abnormalities in their ECG. Then in red, we have certain medications that you could be taking. You have high blood pressure, type 2 diabetes, smoking, high cholesterol, obesity, drug abuse, and high stress. These are all lifestyle factors. So all of these arrhythmias could be solved with the use of a pacemaker slash ICD. Now, not all of them require such an extreme treatment. Some are often aided with the use of a simple medication, but some of them, such as PVT and VFib, will require a pacemaker slash ICD. And you'll notice I write pacemaker slash ICD because most modern devices actually do both. They can keep pace like a pacemaker, and they can issue a defibrillation shock like an ICD. So let's get into it. What is a pacemaker? So a pacemaker is a small electrical device. It's maybe the width of 3 AA batteries, and it's very light. And it effectively creates an artificial nervous pathway in the heart when the natural nervous pathway is ineffective. And an ICD is similar to a pacemaker, but different in its own ways in that it attaches the same way and it inserts into the atria and the ventricles. But instead of keeping pace, what it does is it constantly monitors for abnormal heart rhythms, such as AFib, VFib, or PVT, and it can issue a very gentle defibrillation to the affected area of the heart in which these arrhythmias occur. So the scope of this solution is really quite large. So 800,000 people in the United States have an ICD, and 3 million people have a pacemaker. So this is a solution that works for a very large amount of people. And that brings us to our case study. So here is our case study. His name's Brad. He's 72. He lives in Pennsylvania. And he is generally a very active guy. He walks daily. He performs 30 minutes of cardio exercise. He has a healthy diet. Although recently he has been diagnosed with hypertension due to some weight gain, but it's nothing that, he can't figure out. But something very abnormal is that recently he's been experiencing these onsets of a very fast heart rhythm, upwards of 200, 250 beats per minute. And these attacks make him feel lightheaded, dizzy, faint, and they cause some chest pain. And these attacks will typically last for maybe anywhere from 3 minutes or less to upwards of 30 minutes or an hour. So what is Brad's diagnosis? So Brad is experiencing what we call paroxysmal ventricular tachycardia. And you can see from the ECG here that the regular sinus rhythm will be occurring, and then all of a sudden, almost at random, the ventricles will issue this nervous stimulation in which they start contracting at a very, very high rate. Again, it's 200, 250, even more beats per minute. And if you look at the ECG, it can occur at any time. And you can see how quickly the onset of this state is. It happens instantly. So what's the pathophysiology for this? So there's two different ways that this can occur. There's AVNRT and there's Wolff-Parkinson-White syndrome. So AVNRT is basically when the impulse comes down the pathway. It comes from the SA node, travels down to the AV node. But when it gets to the AV node, instead of just naturally continuing down to the bundle branches into the Purkinje fibers, it starts looping around inside the AV node. And so it's looping and looping, and each time that it loops, it sends another signal down to the ventricles, creating another contraction. So that's what leads to such a high heart rate, is that it's just, it's centripetal. So then in Wolff-Parkinson-White syndrome, if you look at the other diagram here with the heart, it's similar in that it has that repeating loop, but instead of just occurring inside the AV node, instead it occurs by going down through the bundle branches into the Purkinje fibers. But then when it reaches the uppermost end of the Purkinje fibers, it actually travels back through the atria and returns to the conduction system just before the AV node. So instead of repeating inside the AV node, it repeats throughout the entire conduction system, and it repeats very, very quickly. So what's the solution for this? So what Brad will have is Brad will have a pacemaker ICD implanted, and it's a very simple surgery in which a small incision will be made under the collarbone, right about here, and this pacemaker ICD will be implanted, and the wire for the artificial nervous system will be run through the blood vessel back to the heart, and it will insert into the atria and into the ventricles. There's two nodes. So what's going to happen is when Brad's ICD recognizes that he's having a paroxysmal ventricular tachycardic episode, it will send out a very, very small defibrillation to the ventricles, and that will get them back on pace. And this is going to be such an easy surgery. You can see here in the diagram that the only effects of the surgery are that he has that small lump in his chest in which the ICD sits. And when he receives one of those defibrillations, he may feel a little tired. Afterwards, he might feel, slightly jarred. But other than that, it will be superior to experiencing these long PVT episodes of a very rapid heart rate. And really, there's not much else to be said. It is a very good solution. So in terms of his exercise prescription, what we have for Brad is we're going to ask him to start doing resistance training 3 to 5 days a week. And this should be, since he's older, maybe he could start at a lower a lower intensity, maybe, 40% effort, and he'll work himself up from there. But of course, he needs to be very careful with his left shoulder after the surgery, maybe 3 weeks to a month. He should experience some soreness, and an inability to effectively use that appendage. Then for cardio, we'd like to work him back up to where he was with his 30 minutes a day, 5 to 7 days a week. Except it would be better if he could do more than that, and if he could increase the intensity as well, that would be great. It would help him lose that extra weight that he's gained, and it would, really help out his heart in terms of making sure it's healthy and ready to continue. So for flexibility and balance, it should be 20 to 30 minutes, 5 to 7 days a week. And this is because he's getting older. He should really take his balance into concern. And that's it. Thank you very much for listening to this case study. And here's my sources.